And now we are moving towards our next session, and that is on a little bit clinics part. So we'll learn from Dr. Shashank Joshi, who needs no introduction, Padma Shri awardee. He's a very senior endocrinologist at the Department of Endocrinology, Lilavati Hospital, Mumbai. So Professor Joshi will tell us about clinical parts for mega diabetes trials, what clinicians should know. Actually, Professor Joshi is currently traveling. He just present at ACE, American Academy of Clinical Endocrinology meeting. So he had sent one recorded lecture for us, and then we will have some question and answer. So may I invite Professor Joshi virtually and let the video on.
So today we are going to learn about mega trials in diabetes, what clinicians should know. I don't have any duality or conflict of interest for this talk, but this topic is very important and relevant because outcomes RCTs teach and rapidly disseminate what can be done, what cannot be done in prevention or treatment for diabetes outcomes. But they must be interpreted in the context of all that has gone before. So they will impact lives of people with diabetes and make them live longer and live with lesser complications. So we all know this from the blood pressure data, that natural history of a 35-year-old white man untreated with blood pressure dies at 76 with 120 over 80. Will die at 72 with 130 over 90. Will actually lose 4 years at a little higher blood pressure. Will die at 68 if the blood pressure is 140 or 98, which means 8 years of duration. And will die at 60 if the blood pressure is 150 or 100, which is 16 years are lost. Which means we lose years if we don't control them well. So, we are always in a war. And in type 2 diabetes, we are winning the battle but losing the war. And that is what Professor Venkat Narayan said in his Kelly-Voss lecture. That the evidence that we are winning the battle is we are improving risk factors with people with diabetes, declining complication rates. But the evidence that we are losing the war is that higher incidence of diabetes and increasing burden has been a huge challenge. And therefore, when large outcomes or RCTs, they impact patients, HCPs and societies, there is a biology to justify any effect. Non-randomized studies are confounded. Small RCTs are not designed to our CV outcomes or our child's findings or bias assessment. Meta-analysis of small RCTs of outcomes magnify problems which are seen in small RCTs. And large RCTs are big enough that all the randomization equally distributes all confounders into two equal groups, of which one gets treatment. And enough outcomes occur in each group to be confident. So therefore, there are levels of evidence from level A, B, and C, class 1, 2A, 2B, and 3. And therefore, there is a evidence-based recommendation system. So clearly, in today's talk, I'm going to emphasize the role of DCCT in tight glycemic control, type 2 diabetes prevention, care and remission, in prevention of for DPP, Finnish diabetes trial, Chinese, Japanese, and Indian diabetes trial. Type 2 diabetes in UK PDS and their legacy, the big three trials of ACCORD, ADVANCE, and PADT, the game changer trial EMPIREC, and then the direct trial for remission. So clearly DCCT showed us that there is a vascular legacy and tight control matters because microvascular complications are prevented. But the trade-off is hypoglycemia. So DCCT trial was the first trial to show that you can impact there. And when you follow up the DCCT trial, you see a legacy effect or a metabolic memory. And a similar thing which has been seen in type 2 diabetes in mega prevention trials is lifestyle works. So in the prevention mega trials, the landmark trials show us that the DICHING, the DPS, the DPP4, that lifestyle impacts interventions and reduce type 2 diabetes risk across diverse population. They have a global impact on national and type 2 diabetes prevention programs. Their benefit is sustained and the real world implementation remains a challenge. And therefore, we need to diversify the strategies. UK PDS like DCCT was another game changer trial, which was done at the backdrop of the 1960s controversial UDGP program, which apparently showed that tolbutamide had excess mortality, which gave a bad name to sulfonylureas, and excess all-cause mortality with fenfluramine. Unfortunately, that was not true. And they got a small aid from a crop workers foundation. And UKPDS commenced in December 1977. And that trial with simple primary care, led by Professor Turner and later on by Rudy Harman after his death, clearly showed three areas: first phase, second phase, and third phase. And all that it showed us is tight glycemic control, independent of ethnic group matters. And an A1C drop of 1% will reduce diabetes-related endpoint by 12%, microvascular disease by 25%, myocardial infarction by 16%. And this data was consistent and it was persistent. And it very, very clearly showed us that there is a legacy effect. And when we saw the follow-up of DCCT trial, you can see even after 30 years and 45 years of DCCT trial, there is a legacy effect which is sustained and persistently seen. And that data is so clear-cut. But however, that legacy effect is not seen with blood pressure monitoring. So clearly we can see that intensive glycemic control matters, and it does reduce both all-cause mortality and myocardial infarction. And after 44 years of follow-up, you can see that the legacy effect is persistent. So when you see UKPDS at 2030, the mean age at 2030 of those patients will be 90 years. And you can see that in 2022, only 14 patients of original patients had an impressive follow-up of 40 years of life. So legacy effect matters. And this glycemic legacy, hit hard, hit early, actually, if you hit hard in the diabetic's life, the first decade, it matters. That's what the mega trial showed us. So diabetes glucose control matters, blood pressure control matters. The blood pressure control will have a legacy effect. However, the blood pressure control will not have a legacy. So whether it is type 1 diabetes or type 2 diabetes, DCCT headache and UKPDS and follow-up demonstrated a metabolic effect. And this metabolic effect clearly is demonstrated that it will cause, when you hit hard, hit early, functional changes and structural changes and metabolic memory. And this metabolic memory is preventing complications. Here you can see by various plots that if you hit hard, hit early, it will reduce the glycemic legacy and it will impact trial. Similarly, we can see that, when you do this other trials, when they hit hard, hit early late, like advanced VADT, Accord, mainly VADT and Accord, they didn't show that legacy effect. So obviously the other glucose lowering trials had a neutral effect because they had short periods of follow-ups, the endpoint may need revision, they were resource demanding and costly, study populations with cardiovascular damage, few head-to-head comparisons, and so on and so forth. So obviously now we have drugs like SGLT2 inhibitors. They were not inhibitor there then. So if you introduce a SGLT2 inhibitor, can it blunt or attenuate or impact or extrapolate the legacy effect? And that is possible, that is feasible. And we have data from EMPA-REG now, which was a game changer trial, another game changer trial, which showed that EMPA-10 or 25 clearly impacted hazard ratios across board, whether CV, death, all-cause mortality, and clearly showed that it was a very, very high impact trial. After the pre-statin era, we had the ACE era, then we have the EMPA-REG era. So these three big trials, the statin mega trials, the ACE inhibitor ramipril trials, and the EMPA-REG trials were game changer trials, and the outcomes were sustained. So clearly, EMPA-REG had all the outcomes of a good RCT. It had a good protocol, clear and clear cut. It had a high retention rate, high adherence rate, high event ascertainment, clear analysis presentation, and definitely raised more questions than answers. So it was a good outcome trial. And this impacted all guidelines worldwide that for atherosclerotic vascular disease, kidney disease, heart failure, beyond glucose control, this is the second change which a drug like this can do. And that's something which we recognize and we know very clearly. So clearly we recognize that EMPA-REG trials make a difference. Better glucose control can also have a cardiorenal prevention strategy, and that's the need of the hour. The third mega trial which one needs to know is a direct trial. And Professor Roy Taylor showed us that if you just eat less and have a low-calorie diet with the direct mechanism, you will improve the first phase of insulin release. And in the direct trial, very clearly we showed that people between 20 and 65, diabetes not more than 6 years, BMI between 27 and 45, not receiving insulin. Clearly, we could see that in 5 years, there was a very good remission and a follow-up which was seen. And we also showed that if you reduce carbs and proteins, you can modify it. We can use technology to do it. And therefore, what do the outcome trials teach us? They teach us very clearly that if you are able to understand them, they clearly tell us what does not prevent or treat diabetes outcomes. They must be contextualized and interpreted for all that has gone before. And they impact people's lives with diabetes and make them live longer and live lesser with no complications. Thank you so much. But my last point is that mega trials in diabetes space, whether it is prevention, whether it is remission, or whether it is reduction of disease progression, they are all here to stay. And therefore, it's important to remember that lifestyle is supreme, but medications do work. Thank you so much for a patient here.
Thank you, Professor Shashank Joshi, sir, for your wonderful deliberation. I think as we have some time, we'll try to summarize this talk. As we had already told that Professor Shashank Joshi is currently at ACE. So whatever we learned from this lecture, just a summary of that particular lecture. The mega trials in diabetes, they are large scale, multi-center, randomized control trials involving lot of thousands of participants across diverse populations. So there should be a high degree of heterogeneity. These trials aim to produce high quality, generalized evidences for different diabetes treatment strategies, particularly in relationship to cardiovascular and renal outcomes. So clinicians must understand not only the outcomes of these trials, but also the nuances of trial design, patient selection, endpoint interpretation to apply the evidence effectively in their real-world practice. So if we talk about a few key scientific insights summarizing Professor Joshi's talks, then number one, the CVOTs, cardiovascular outcome trials. So there was a paradigm shift. CVOTs became mandatory post 2008 saga. We know the rosiglitazone saga, the FDA guidance for all new antihyperglycemic agents to ensure cardiovascular safety. Therefore, we got trials like EMPA-REG outcome, Canvas, Declare TIMI 58, and Leader, and so on. Now we are also giving very recently, we get the results of Surmount and all the other semaglutide, oral semaglutide trials also, which have shown that certain agents, especially the SGLT2 inhibitors, GLP-1 receptor agonist, and now the dual GLP-1 GIP analogs like tirzepatide, offer us CV and renal protection beyond glycemic control. Then number two, beyond glycemia, our focus is on organ protection. So the modern paradigm stresses that glucocentric approach, the only glucocentric approach, is outdated. New agents should be selected based on organ benefit profiles, be it heart failure, be it CKD, etc. Now we are talking about MSLD also. For an example, the empagliflozin, sir had taken the examples of EMPA-REG. So empagliflozin reduces risk of CV death and hospitalization for heart failure, independent of HbA1c. Now, third point, diversity and subgroup analysis matter. So mega trials often included tens of thousands of participants, but real-world representation. For an example, in our setting, South Asian population, elderly population, women may still be limited. So we need to dissect the trial data with vigilant eyes. So subgroup analysis help assess efficacy across ethnicities, comorbidities, and baseline risk. So these are crucial for countries like India with unique disease patterns. Fourth point, understanding surrogate versus hard endpoints. Earlier trials emphasized HbA1c and microvascular outcomes. Now we are talking about MACE, major adverse cardiovascular events, renal composite outcomes, and mortality. These are prioritized. So clinicians must discern whether those trial endpoints reflect true clinical benefit for their patients. Fifth point, neutral versus positive trials. Don't ignore the neutral ones. Very important, because not all trials show benefit. For an example, examine trial, SAVOR TB, they showed neutral CV effect. So these findings are still critical for therapeutic safety and help shape the patient-specific drug selection. So if we want to summarize these or translate this into implication for clinical practice, number one principle, personalized therapy, select agents based on comorbidities profile, be it atherosclerotic cardiovascular disease, chronic kidney disease, heart failure, and now we are talking about MSLD. Number two, therapeutic sequencing. Prioritize SGLT2 inhibitors or GLP-1RA in patients with high cardiovascular or renal risk independent of HbA1c. We got now the Emperor reduced data, EMPA kidney study, DAPA CKD results, DAPA HF results. Number three, safety and tolerability. So be aware of adverse events specific to drug classes. We know SGLT2 inhibitors and their risk of mycotic infections, genitourinary tract infections, how we can prevent those. Gastrointestinal side effects with GLP-1 receptor agonist. We need to know this. Then number four, outcome interpretation. This is very important. We need to evaluate the absolute risk reductions. NNT calculation, that means number needed to treat calculation, not just that those relative risks, because this will give us more realistic understanding of the therapeutics which are using. And fifth and most important, especially in our country, cost and accessibility to treatment. So when we talk about accessibility, it covers both availability and affordability. So consider affordability in countries like India while extrapolating those global clinical trial data. So this is very important to know. So to summarize, primary prevention data in lower risk populations, we need to find out. We need to do some more research on that. Long-term microvascular outcomes, how Indian cohort is representing in the global clinical trials. And now we need to integrate real-world evidences with RCT findings. So I think whatever we learned from Professor Shashank Joshi's lecture, this scientific framing will help us translate evidence from mega trials into bedside decisions that improve both glycemic and non-glycemic outcomes in patients with diabetes. So